We are thrilled to welcome you to the Global Special Interest Group of DCCFAR update. We gathered today to give you some of the highlights of the IAS conference that took place in Montreal in July. And we are thrilled to have you with you and have your interest in linkage and finding the stronger linkages between the research we are all doing in our respective institutions and our roles in DCCFAR, and looking for the potential exploration of the research that can link us more to global health agenda. Next one, please. And as I welcome you, we will go through agenda very briefly. We are welcoming you with our new coordinator and administrative support from DCCFAR, Vivian Kikram, who has been wonderful to work with and who has put together this webinar today, or this discussion panel together today with presentations. She will give you a brief overview of the IAS conference. We will move on then to my presentation, which not surprisingly will focus on pediatric and adolescent. And Julie Pullerwitz, whom I'm very, very happy to introduce equally as my co-chair of the Global SIG at DCCFAR. And we will do introductions briefly. We'll move on doing her presentation with a focus on key population progress. We are thrilled to welcome Dr. Yang Wan, Associate Professor from George Washington University, to present her presentation from IAS conference this summer. And then what we hope to move on is a really robust discussion with you, making connections, asking questions, telling us about your research, and that will be moderated by the third co-chair of the Global Health SIG, Khadija Abdullah, and she's our community lead and also a prominent community member. And we will adjourn at 11 a.m. Next slide, please. And I will just start by very brief introduction of all of us. I am Natalia Rachmanina. I am MD, PhD. I work at Children's National, and I am a professor at George Washington University. I also work as a senior technical advisor at Elizabeth Glazier Pediatric AIDS Foundation, and I'm thrilled to co-chair the Global SIG with Julie and Khadija. And passing on now, introduction to Julie.
So good morning, all. I think it's morning for everyone who's joined us here. And thanks so much, Natalia. My name is Julie Pullerwitz, and we are the newly constituted Global Scientific Interest Group team. So it's really great to have this meeting. This is, I think, pretty much our inaugural meeting with us as the co-chairs. So I am one of the co-chairs, as Natalia was just saying. I'm based at the Population Council, and we are developing a closer relationship with the DCCFAR, so I'm very happy to take on this role. I'm trained as a socio-behavioral scientist, have been leading the HIV program at the Population Council for some time, now under the socio-behavioral umbrella, and I'll stop there and turn it over to my co-chair, Khadija.
Thank you. Good morning, everybody. My name is Khadija. I wear a few different hats. I'm the founder of Rahma. We do HIV work, sexual health work in faith communities. I also work at Children's Hospital, Dr. Rachmanina, she's my boss. And I go here as well to DW. I'm pursuing my MPH here at DW. So excited to be here and be part of the SIG and for this really robust and great conversation. And pass it on to Vivian.
Great, thank you, Khadija. My name is Vivian Kirkham, and I'm the administrative support for the Global SIG. I am also the core manager for the developmental core, the basic sciences core, and the clinical and population sciences core. I also help with the women in HIV and administrative support as well through the DCCFAR, so I'm excited to be here. I'm going to go into just a brief overview of what the IAS conference looked like and what it entailed, just to give more context as to where these presentations were given. So the 24th Annual International AIDS Conference, also known as AIDS 2022 or IAS Conference, is the largest scientific HIV conference for scientists, policymakers, community members, and activists. It was held as a hybrid conference in person in Montreal, Canada, and virtually from July 29th to August 2nd this year. And it was the first time international HIV researchers and community members were able to gather in person since 2019. This year's theme was re-engage and follow the science. And the conference provided a forum to, quote, convene, educate, and advocate for a world in which HIV no longer presents a threat to public health and individual well-being. So here's just a list of a few of the featured speakers from this year's conference. I'm sure there are a few names that you recognize here, but this also shows that speakers from all over the world comes to participate and in this conference. And this year, around 2,000 speakers were able to participate and were featured in the conference. So just a bit more context as to what the program entails. There are a few different types of sessions. The prime sessions feature HIV scientists, policy specialists, and community leaders on pressing HIV issues. Satellite symposia provide organizations with the opportunity to host their own sessions at the conference, and some of the organizers include JPIGO, EGPATH, UNAIDS, PEPFAR, Gilead, and so on. Symposia sessions feature research findings and consist of brainstorming sessions on clearly defined issues that need a rapid response. And this also includes oral abstract sessions. And there were about 300 posters that were featured in the poster exhibition in person, and about 1,200 posters featured on the conference platform. The Global Village and youth program also offer a space for connection by showcasing live performances, film screenings, and panel discussions. So there are a few key takeaways from this year's conference. Just a few days prior to the conference, UNAIDS released a report entitled In Danger, indicating that there were 1.5 million new infections this past year due to the COVID-19 pandemic and other global crises. Disruptions to HIV services during the pandemic prevented many people from accessing life-saving medicine, including 10 million adults and half of all children living with HIV. The report suggested that global response can get back on track, and the IAS conference was a call to reinvigorate science as an important and necessary tool in ending the HIV epidemic. Some of the key themes from this year's conference include a need for greater attention to aging and comorbidities in people living with HIV. There was a symposium on metabolic consequences of new classes of ART that found that people who are over 50 have been poorly represented in randomized and observational clinical trials. This has caused difficulties for health providers to provide adequate care. And as the population of people living with HIV continue to live longer, more research is needed to better understand how to best provide care for this population. Community engagement is also essential for effective and efficient control of HIV. Multiple sessions, especially during the Global Village, found that there was importance in engaging the community in decision-making. And the Nothing About Us Without Us session highlighted community work in decriminalizing sex work, strengthening peer support in LGBTQ+ communities, and the importance of trans experiences. Implementation science is also important in building sustainable health systems. Many presentations during the conference highlighted that implementation approaches such as differentiated service delivery DSD models work to improve patient care and outcomes, especially during the peak of the COVID-19 pandemic. And then finally, throughout the conference, an overarching theme was the impact of the COVID-19 pandemic and the emerging monkeypox disease with HIV. There were sessions that highlighted the similarities between the COVID-19 pandemic and the HIV pandemic, especially on their impact on vulnerable populations. But it also highlighted the differences in stigma, health disparities, and leadership responses. The Global Village sessions also showcase successful responses from the community when addressing the COVID-19 pandemic, and these lessons and tools can be used to address future pandemics and emerging diseases more effectively. Here's a list of the DCCFAR members who participated and who were in attendance at this conference, whether it was through an oral abstract session, panel participation, or poster presentation. We had great representation from our DCCFAR community. Now I'm going to pass it to Dr. Rahmanina for her presentation.
Thank you so much, Vivian, and thank you again all for attending. And you gave a really nice overview, a very complex and very big conference with a very interesting history. So those of you who have time, you want to learn more, there've been some really great advancement that this conference was able to introduce to global arena and fight against HIV epidemic. I will be focusing on pediatric and adolescent HIV and just doing a few highlights. Next slide, please. And I want to start by paying a very special tribute to a very long-term colleague of mine and true leader in pediatric and adolescent HIV globally, Lynn Moffinson, who is a senior technical advisor at TechPath and participates a lot in the research community and activities in multiple countries. Has been a leader at NICHD for many years. And those of you who work in this arena know that following any major conferences, would it be CROI or IAS conference, Lynn has been compiling absolutely amazing set of slides. Many of us have used it, and I will be presenting her slides today. Some of them are adapted to my contest, but just paying a true tribute to her incredible resource to the whole pediatric adolescent community globally with a summary of the slides and recognizing and acknowledging the use of her slides, which she kindly shared with me. Thank you. Next. And I wanted to highlight just 3 of the posters. What I will be talking about will not only be from IAS conference. There is a very well-respected pediatric HIV conference that also covers some of the adolescent agenda as well, that takes place usually just 2 days prior to IAS conference. This is actually a highlight for pediatric adolescent community. I know that some people who can't stay even through the whole conference for multiple reasons, they actually make every effort to attend it to a pediatric workshop. And it allows for the co-submission of the abstracts. And we have seen throughout history different trajectories. Some co-submit and some do not. And they're equally very valuable abstracts. And I just want to highlight, we presented work on the mental health of the woman and decision of breastfeeding in our community. And one abstract was co-submitted on STI rates in adolescents and impact of COVID. Next one. I will not be covering those studies. Anyone interested, I'm very happy to engage. This is some of the demographic. I think, Vivian, you already mentioned some lack of progress with pediatric populations, but basically in a number of pediatric infection, whether the major source is a perinatal HIV transmission from women who live in with HIV, we have made extremely little progress and basically no progress. You can see in orange bars the percentage of women globally who received antiretroviral drugs in pregnancy, and in the blue line, the number of vertical infections or perinatal infections. We very much missed our 2020 target of 20,000 new infections. And you can see the line is flat practically in the last 5-6 years. And we continue to see around 160,000 new pediatric infections each year. And if we continue with that pace where we had zero progress or progress only within 10,000 decrease yearly, it will take us until 2035 to meet our targets, which we already missed in recent years. So we really cannot continue at the same pace. And that has been a message throughout both conferences. Next slide. And as you look at the number of infections and where they occur, you realize that approximately half of this estimated 160,000 new infections occur because pregnant women were not diagnosed or started on treatment. There's a big yellow bar in the middle of the bar graph on the left. Equitable amount of women in orange and gray bars were mothers who were either infected during pregnancy and breastfeeding, or that were infected before but did not continue on treatment during pregnancy or breastfeeding. And a very small proportion of women were new incidental infection, less than 10%. And most of that were seen in the areas of the good coverage with maternal ART during pregnancy, such as East and Southern Africa. And almost all of those that were not receiving treatment, half of those, significant proportion, were in West and Central Africa. Next slide. When the babies are born to the woman living with HIV, one of the most important next steps is to establish the HIV status, because based on HIV status, we can either offer them early treatment, which you know is beneficial, or we can make a certain conclusion about their status and move on with other testing at the end of the breastfeeding period if they're breastfed or at per WHO guidelines. However, we're still failing behind the target of testing the infants after they are born for HIV. This is called early infant diagnostics for those of you not working yet in a global arena. And here you see in the gray line the progress in the last 10 years in the number of infants who received the result of HIV testing by 8 weeks. And you can see that we have not done really well. We are still slightly over half at 62%, actually decreased slightly from previous year. And again, you see significant regional differences. In West and Central Africa, where we know maternal ART coverage is an issue, you see very low rates at 25%, actually decreased. In the recent couple of years, you can see the curve going down. But in East and Southern Africa, it's good progress. It's high, but it really slowed progress. Equally, you can see the line flattening, and we are going down there as well. Next one. And when you look at the coverage with treatment, and that's exactly what Vivian mentioned before, we know that globally under the age of 15, only half of children roughly consistently receive access to treatment. That's a consistently low number. You can see the line is flat. And while adult line is slowly moving up and making some progress, we are still staying flat with children. And 60% of these children are age 5 to 14 years, telling us that early infant diagnosis is not the only way for us to reach those infants, but we really need to also diagnose them later in life, and different modalities have been proposed to try to intensify case finding in children that are older than 5 years. Next slide. And then one of the studies I really wanted to highlight was presented at the pediatric workshop. It was conducted in Uganda and Zambia, and it's an interesting study where they evaluated the acceptability, feasibility, and effectiveness of implementing caregiver-assisted oral fluid HIV testing of infant screening of children in 16 districts in Uganda and 2 provinces in Zambia. On the right, you can see the algorithm they used. They found index parent caregiver that was positive. It could be a woman or man, and it could be emancipated minor in Uganda. And eligible children basically meant all biological children of an adult index case. In one of the countries, non-biological children living in the same household were included, I believe in Zambia. And also the children that if they were in a household, if the mother was deceased, unknown status, or if the child was positive, that child was excluded, but otherwise unknown status was also eligible for testing. They offered the caregiver to take either oral tests back home with them and test the child at home. Second option was to bring the child to the facility and have the child tested with a blood test. And third option was to have a community health worker to come to the home and test the child through the blood test. And what they have shown really remarkable, a very high acceptability. You can see close to 97% of eligible index parents and caregivers accepted oral test kits. They sent a large amount of these test kits home, and close to 98% of children were tested and returned results. And you can see in the bars, these green bars in the middle of your slide, these are returning for the confirmatory test results to the facility within 1 week. 58.8% have returned, which is really high. And you can see as the time goes by, the number grows. And the most important is over 1 month's period of follow-up, almost 98% of children have received confirmatory testing. Those who received the reactive test results, they were 1.6% of all tested. 98% of them completed blood testing facility, and you can see clearly how it can decongest. Importantly, 37.1% of 43 children have been found positive for HIV, had confirmatory test, confirmed infection, and 42 of 43 started the same day ART. So this is just one of the attempts and one of the models where we are looking at resolving that gap that we have just identified in missing those children on treatment. And that is model definitely deserves further evaluation and assessment of its implementation capacity in other countries and in other settings. Next slide, please. And when you talk about the treatment, we also had some really good news. There were 2 studies from Baylor Initiative that looked at multiple countries. This was a larger cohort study that they presented at Pediatric Workshop and equally at the AIDS conference. They analyzed data retrospectively from 7 sites in 6 countries listed on the map on the right, almost 12,000 children. And as we all follow DTG switch based on WHO guideline or switch to dolutegravir-based ART, questions have been raised about sustainability of the viral road response, etc. And in this cohort, probably the largest cohort to date, majority of children were more than 10 years. Naive were only 21%. The rest were treatment experienced, and very high proportion, 95% were virally suppressed at baseline. If you look at the green line on the left at the bottom of the screen, you can see the follow-up time period was 22.4 months. They do have children that are followed up to 60 months, but they are the minority in the sample size. So right now, the analysis that you are seeing is through 22.4 months. And you can see the rates of viral suppressions were maintained very high. There was really no difference in suppression by sex, age group, or NRTI backbone. And what importantly, in the light of NADIA trial results, we're asking ourselves what will happen with the backbone in children, because such a large proportion of them are exposed to abacavir. They took a subset of 210 children where they had the data and analyzed them on the unsuppressed children and analyzed the data on them on viral suppression if they just substituted dolutegravir, and analyzed it based on the drugs in the backbone. And you can see the majority were on abacavir followed by TDF, very small proportion of children on AZT backbone in the purple color. But the good news is that if you look at the 4 post-switch DTG viral load measurements, they were all maintaining a high level of the viral suppression. So this is limited number, but there is some signal for us, and it really helps us to determine whether the NADIA trial results are applicable to pediatric population. So we're looking forward to seeing more data from this analysis. Next one. And just final on the pediatrics before I switch gears for the last few minutes on adolescents. This was an interesting study from Penta Network looking at EARTH apical cohort. They followed 212 infants who started treatment very early. And we all know the benefits of early treatment, but we also know that early treatment doesn't mean sustained adherence. This is a multiple country cohort. They follow children up to 2 years. The children majority on lopinavir, ritonavir based treatment, as you can look at the left. And unfortunately, we do know that despite the fact that they started treatment at 1 month of age on average, the suboptimal adherence was observed only at 56%. The probability of death was still very high, 11% after 1 year, 12% at 2 years. And the most important excess of overall mortality was 7%. So unacceptably high rates of death still in children who have access to RT and started it early. 52% were dying from AIDS-defining causes and 48% not from AIDS-defining causes. And when they tried to tease out the relationship, it looked like there was some inverse relationship with the CD4 count as it progressed, and it was a baseline viral load. But this is really a worrisome slide, because what you see here is that despite early treatment access and an efficient regimen, challenging regimen to take, but efficient regimen, we're still observing excess of AIDS and non-AIDS related mortality in children, and we need to develop more comprehensive package of services. Next slide. I will be switching now to adolescents for the last few slides. The adolescent news were not also equally not encouraging. You can see here the overall mortality from AIDS on the left of adults 15 years and older, and then sub-analysis of the youth specifically 15 to 24 years of age. And it doesn't take long to see that the curve is much flatter on your right. So we're not observing the same decrease in mortality in young people as we see in adults. An interesting reverse gender leading proportion of gender mortality. In males, overall in adult cohort, the mortality is higher, but in adolescents, females lead the mortality statistics. Next slide. And with adolescents, just to highlight the importance of the overall package, I will not be talking about the therapeutic modalities, but rather we know how complex adolescent ART is and how complex it is to serve these populations through this transition period of their life. And I saw this was a very interesting study presented at IAS conference by Lucy Clover from Oxford. She has been doing fantastic work in this direction. This study in particular looked at the impact of intimate partner and sexual violence on ART adherence in adolescents in South Africa. They had a very large cohort of 1,000 adolescents. And if you look at the gray circles, you can see that 37% overall of the cohort had exposure to IPV or intimate partner violence and sexual abuse, 23% of females, You can see 11% had exposure in the last year and 5% had both the exposure of females had exposure to both forms. Very interesting graph on your left, bar graph on your left is adherence. And you can see that adherence diminishes from the use, from 72% among the youth that had no exposure to IPV or sexual abuse to those who had dual exposure, going all the way down to 38%. And the same in multivariable association between IPV sexual abuse and past week reported adherence, direct adherence in just last few days by almost 1,000 adolescents confirms this relationship. And this really highlights that in adolescents, we can't just focus on the treatment. And this particular abstract and study has suggested that we really need to include IPV and sexual violence assessment on all interactions with young people, make system of referrals and multiple tools listed here on the slide in print, and technical tools, digital tools were introduced to really increase our attention to this part of young people's life. Next slide. And a couple of more studies that I will cover before I finish is one study from Uganda that focused on NGO Allied Medical Services working with young people who are not virally suppressed. We all know there are multiple clubs and supports to young people who are not virally suppressed, different attempts. Here, what they did is a matched mentorship model. They matched unsuppressed youth with youth that were suppressed. They conducted group meetings, maximum amount of 20 people. They were all matched by age cohorts every month. And in addition, they made the matched contacts and mentors work with youth that were not virally suppressed in between those meetings and used community linkage facilitators, and meetings took place both personally and virtually. This is a small study, but the model seems to be very promising. Uganda, out of 28 youth who were not suppressed at the start, 22 achieved viral suppression, 2 were switched to second-line ART and are being followed. And so this model is now proposed at the national level to be expanded to other areas in Uganda, highlighting the need to really work with those who are not suppressed on a regular basis and engaging them with peers. And last study I want to highlight, next slide, is the SIG study. This is a multi-level health system intervention was conducted in Kenya and Uganda among large number of adolescents, over 2,000 adolescents 15 to 24 years of age, and they have offered them in 28 clinics multi-level interventions. These 3 major components of this multi-level intervention was capacity to choose alternative clinic visits for young people, was the assessment of the life changes, life stage changes, what's going on in their life. It's a standardized assessment that was conducted regularly. And finally, rapid delivery of viral load results. And there were other components like collaboration between providers, etc. But these were 3 major components. And if you look at the results in the blue bars in the left and alternative clinic site visits by clinic sites, you can see they varied by clinic sites, but overall you see the majority of the bars being blue. And this is you selecting off-site appointments, off-hours appointments, selecting phone appointments, follow-ups, and off-site drug delivery. They had a really good uptake in the life stage assessments among young people, and among those that they followed in the region, almost 85% had at least 4 or more life stage assessments in a 2-year period. And finally, when you look at the timing to viral load results delivery, it was really very well done. They took less than 2 days, 38.4 hours median for deliver results of the viral suppression, 13 or 14 clinics that they reported data on. Next slide. And here are the results, and results are really looking promising. At baseline, you can see control and intervention, very comparable viral load suppression. But if you look at the end line, you can see that much better viral suppression was observed in those in intervention cohort. And there were no significant differences by age and sex. However, there was a better uptake and better results in 15 to 19 years of age cohort. When you look at the viral suppression among those who were engaged in care, recently engaged or re-engaging, In re-engaged cohort, that's where they saw the biggest difference. And one might recognize, and it's shown on the right of the slide, that during that project, a lot of youth have switched to dolutegravir-based regimen, but they switched an equitable number between both cohorts. And even when accounted for that switch, this data on the right, it's still results of the viral suppression were better in intervention arm. So just in summary, this is a really good study that also accounted for some, and was able to offset some of the detrimental impact of COVID pandemic. But this is a really good study showing that the package of intervention with these three major components could produce a tangible results in the viral suppression among young people. And my last slide is just to really acknowledge the highlights from this summary. We really have missed and continue to miss pediatric HIV prevention targets, and we will not achieve them if we do not intensify our efforts. Young children less than 5 years and adolescents remain most challenging population along the diagnostic and care cascade, and implementation of novel and more effective ART definitely has promising results, as we've seen in Baylor data. However, we also see with adolescent and other data that we need truly multidisciplinary, multi-layered intervention, and we need more service packages to optimize pediatric and adolescent outcomes beyond just availability of better drugs. Thank you very much, and I now switch to Julie.
Thanks so much, Natella. You're right, there's such a great set of slides. What a great overview. So much going on. And I see that we had one or two comments in the chat that we'll get to. We're going to be holding comments and questions till after our three presentations are completed, and hopefully have a nice discussion after that. So my take on the presentation today, I will be sharing a selection of contributions that I was involved with for AIDS 2022. And they I was trying to think of what is an overarching comment about them. I think that I would say that there's a focus on stigma and gender dynamics in the context of HIV, and particularly for vulnerable populations, like key populations like men who have sex with men, transgender population, as well as adolescent girls and young women. And so that's kind of the overview, and I'll be sharing a little selection, some snippets from different either posters, presentations, papers that were shared at the conference. So thanks very much. Next slide. It's going to start with the in-person poster that our team, I was involved with, but this was led out of Nigeria with our first author, Anita Fernandez, there around HIV self-testing. And that came up, I think, in Natella's presentation too, about the promise of HIV self-testing for children, the pediatric context. And here we're highlighting the promise of HIV testing amongst key populations. So as you all know, it's a highly confidential alternative, and one that is being explored in different contexts for highly stigmatized populations, like men who have sex with men and the transgender men and women in Nigeria. It's a population that's criminalized as well as stigmatized. And so this was an exploration in reaching more people through offering HIV self-testing, see if you're able to reach those who are more at risk, and see how well you can link them to care. Also being aware in this context, follow-up is quite a challenge when you have self-tests, because you're trying to understand. So now someone knows that they're positive or negative, but how do you link people to care most effectively? And so this strategy was to use community-based distribution, as well as linkage to ART and for those who are living with HIV, as well as PrEP for those who were negative in Lagos, Nigeria. So kits were distributed to over 1,000 men, men who have sex with men, about 250 sex workers, female sex workers, and over 100 transgender persons, both transgender women and men, by peer educators. And so this is the poster on the right that we can look in more detail about later, but I think I just have one slide, the next slide, on some of the key results. Next slide, please. And what we found was that almost 20% of the kit recipients were first-time testers. So people took kits through community-based as well as through connection online, and almost 20% were tested for the first time. We also saw, if you look in the bar chart at the right, that there was a substantial rate of HIV positivity amongst self-testers. So that's another question that we have around yield. How do you best reach those who are most vulnerable? And here we found over 3% were positive amongst self-testing men who have sex with men, 5% of the transgender population, under 1% of the sex worker population. We also reflected and found that the positivity rate, in fact, was higher through members of key populations accessing the test via social media as compared to in-person services. So that's the positivity rate, although fewer people were reached with social media as compared to in-person services for this outreach effort. So one of the conclusions that was drawn is that strategies were needed to improve the ways to reach the key populations, the key audiences for this program in the context of Nigeria through social media. The other conclusion is that we found that there was very high linkage to care in this context, and that is unusual, and that's likely due to the fact that this program also includes in a key population friendly services, and there are very few for at-reach men in the Nigerian context. I mentioned that it's criminalized and stigmatized populations and behaviors. And so because of that, key population friendly clinic, as well as the rapid follow-up with the testers, so that the peers also reached out to connect testers to services very quickly afterwards. We had extremely high linkage to care. So that was sort of a promising strategy. Next slide, please. The second piece that I wanted to share about key populations was in the context of stigma. So HIV stigma, as well as stigmas related to being a member of a key population, sexual or gender minority, or for that matter, sexuality in general for adolescent girls being sexually active and the stigmas related to that. Lots of intersecting important stigmas that lead to people being at risk of HIV, as well as less likely to access care effectively and adhere, as it came up, I think, in an earlier presentation as well. And so I've been working in the context of stigma for a long time, trying to kind of understand how it manifests, trying to measure stigma more effectively quantitatively, trying to show that stigma is in fact related to these outcomes, trying to develop stigma reduction programs. So for example, we have an internalized stigma reduction program that we're piloting in that context in Nigeria that looks very promising, as well as trainings and for providers to reduce sort of experienced or external stigma. And this was a paper that was published at the AIDS conference. So the International AIDS Society runs this every other year enormous conference that Vivian was describing. And their journal is the Journal of the International AIDS Society. And so they put out a special issue every 2 years, so every AIDS conference here. And one of our papers was highlighted in this special issue. So this special issue looked particularly at stigma and how it affects the continuum of care. And so this was presented in the context of a pre-conference meeting. Natella mentioned that as well, that there are a series of pre-conference symposia, which are usually excellent and very well attended. And this one focused on stigma. It was called Getting to the Heart of Stigma. And it was also hosted by the conference organizers, IAS. And so one of the papers, it talked about many different issues, but this paper that I wanted to highlight focuses on stigma experienced by transgender men and women in Nigeria, also in the context I just described to you, and how that influences their access and success within HIV services. Our first author here, I was part of the team, but the first author here is Waymar Chun, who is also joined the DC CFAR group. I'm not sure if she's here this morning, but is going to be working with us going forward. And this particular study I already mentioned, looked at how stigma influences the continuum, the HIV care continuum experience. So this was a qualitative study that included both in-depth interviews and focus group discussions with both transgender women and transgender men, as well as speaking to staff and representatives from community service organizations that work with HIV and transgender health in general, of which there are very few, as well as 10 healthcare providers more broadly, part of health facilities that work with HIV, but not necessarily with key populations or vice versa. Next slide, please. And a couple of themes or insights that I wanted to highlight here. That first is around disclosure of gender identity at all. That it's really challenging for transgender men and women, as they shared with us, due to anticipated stigma. What they expected would be the reaction to sharing this with health providers, as well as experiences of stigma they've had in the past in the healthcare context. So it's really often this is the first place that people engage stigma. It's in the healthcare context where you're going to look into being HIV positive, being tested, diagnosed, et cetera, et cetera. And so this is a really important audience for all of us, I think, to be aware of this, as well as to explicitly address. And I think many people are around the world doing that. And it was discussed during this pre-conference. Another theme that came up was the fear of being turned into authorities. So when you're working in a context of criminalized behavior, in this case, same-sex behavior being criminalized, there's a great fear of this institutional stigma as well. And it was also a major barrier to open communication with providers. So it's important to be aware that even in a safe context, what's going on around you and around the clinic and outside of that room really influences people's behaviors. Thirdly, providers were very interested in providing high quality of care, not compassionate and not stigmatizing care. However, they reported a lot of difficulty discussing or soliciting gender identity as well. And so there are skills that we really benefit from developing skills in gender affirming care. Fourth, that the participants reported a conflation of transgender men with lesbian women and being transgender women being gay or having sex with men. So these, that whole grouping, which in general in studies and surveys had been all grouped into one group over time in the HIV field, but has been more recently over the last years really been separated and much more attention to the different needs of the transgender population as compared to men who have sex with men, for example. That we're moving in that right direction. But in this case, our participants reporting it constantly being conflated and therefore their needs not really being addressed or understood. And then finally, non-inclusive or gender affirming HIV services can reinforce HIV stigma even when the services are adequately offering other HIV services such as testing, et cetera. So it's really important to include that component for different populations that you're working with, of course. Next slide. So the next set of papers, studies, presentations I'd like to share with you, and that's my second and final grouping, is under the umbrella of the DREAMS program. And so backing up just a bit, those of you might be aware that PEPFAR, USAID and PEPFAR writ large, has been implementing a program called DREAMS since about 2014, 2015 is what I recall was the first meeting I attended, where it's a focus on reducing HIV risk for adolescent girls and young women, reducing incidence, as well as prevention and linking to care their partners, their male partners. And the reason this all started was because of the extremely high incidence rates of adolescent girls and young women in Eastern and Southern Africa compared to young men. It was something like, at the time, it was something like 8,000 girls a day. No, it was a week were acquiring HIV, and I think now it's something like 6,000. And so it's reduced somewhat, but it's still enormously high incidence in these contexts. And thus the DREAMS portfolio of work started. And underneath this portfolio, Population Council has been the implementation science partner. And so asking different types of questions of understanding what are the dynamics, what is effective to try to reduce risk and incidence, reaching men, rolling out PrEP, which was new, entirely new for adolescent girls and young women in Eastern and Southern Africa at the time, and in many contexts still is. So those are the types of questions we had asked over time. And there were 10 research activities across 7 countries that are named here. And at the AIDS conference, we published a special issue highlighting some of the sort of impact results from this portfolio of work. And so I'm going to share with you, I think, 4 papers, highlights from 4 papers. Did I cover all those points that I wanted to make? I think that's enough. Next slide. So this is the core package of DREAMS, and this has been funded by PEPFAR and implemented by many, many partner organizations around the globe, particularly in Eastern Southern Africa, as I mentioned, but then it expanded. The Global Fund took on this package or a version of this package. Many different donors are implementing this to try to meet the needs of particularly at-risk adolescent girls and young women, and their extremely high incidence rates. And so you see here the center are these colors, these 4 groupings. So it's around empowering girls and young women and reducing their risk. So really meeting their needs through safe spaces, et cetera, to mobilize communities around them. So in this case, a lot around promoting gender equitable norms and behaviors, strengthening families of the girls and young women. Many are living with these young women, and reducing their risk of their sexual partners. And so the key here is that the plan has been to layer all of these types of interventions in one location where they had the highest incidences to see what is the impact of this multi-sectoral group of programs. Next slide. And I'm going to start going more quickly because I know we're going to run out of time. So the first is around optimizing outcomes for girls and young women. One paper is around how exposure to these different packages, these different combinations of activities, led to reduced risk in some way in Kenya. And so this is based on survey data with both adolescent girls and young women, about 800 during DREAMS, and used in kind of an innovative analysis, card analysis, to identify the best predictors of condom use, lack of transactional sex, for example, and no violence exposure. Next slide. And here our lead slide is Sanyukta Mathur. And so these pathways, you'll see the 2 points here. One is that there are differences between the youngest 15 to 19-year-old group and the older group of 20 to 24. And we found that for a number of different points around DREAMS, that there are different needs. It's important to segment your population. So different needs for younger women and older women. And it was really the combination of schooling, parenting, and financial support that helped older women and made it most likely not to have a negative outcome, while it was really the schooling that made the difference for younger women, the 15 to 19-year-olds, the adolescents. Next slide. We also look at costing issues, compared the unit cost of providing DREAMS interventions. There's not a lot of costing information for this type of complex intervention. Next slide. There, Jerry O'Call was our first author. And we found that the unit costs were higher in peri-urban areas compared to urban areas, so twice as high. And here we had the differences driven mainly by the building space and the utilities, because they had more, in urban, you were able to combine services more. And so a conclusion was it was important to strategize around lowering intervention costs, such as using existing infrastructure as opposed to building new clinics, for example. Next slide. So this is our third of 4 papers, and here we're turning to the men. What's going on with the men and male partners? In the beginning of this study, all of these studies, there was a big question of who really are the male partners of these young women. So there was an assumption that they were much older. There was an assumption of who they were. And it found out that there were several different groups who engage in a lot of risk behaviors, both an older group and a younger group. And it was important, again, to diversify or differentiate the types of services offered to these different groupings of men. But here, what I want to highlight are some of the challenges that men experience and the traumas that they experience and adverse events growing up and in their lifetime that then are associated and lead to some of these risk behaviors that affect both them as well as their partners. So this took place in, we were looking at this in 3 sub-Saharan countries, cross-sectional surveys at hotspots and service sites, over 1,000 in Eswatini, about 1,000 in South Africa, and about 600 in Malawi. And I'm the first author here. Next slide. What we see here is that men's exposure to violence or adverse events in their lifetimes is very, very, very high in these contexts. So 60% witnessed an armed attack, for example. 40% were robbed at gunpoint or knife point. And 3/4 were beaten often before age 18 at home. And almost 1/4 saw or heard their mother being beaten before age 18. So a lot of violence, a lot of adverse events. Next slide. And then we saw, and just put this slide up, but there are various other analyses we did, we saw a very strong dose relationship between exposure to adverse events and a number of outcomes that we care about. So those who were exposed to these adverse events that I was just telling you were more likely to engage in transactional relationships. They were more likely to have multiple partnerships. They were more likely to perpetrate IPV, intimate partner violence. They were also more likely to engage in very hazardous drinking, and also much more likely to report being depressed and anxious. So it has effects for the men as well as their partners. And you can see this dose response based on how many exposures they had. So you had 1 versus 1 to 2, none versus 1 to 2 versus 3 or more. So you really see that strongly here. Next slide. And this is the last of the 4 papers where we were looking at the effects of programming on men over time. The DREAMS programs were particularly focused on young women. And so activities for men were just getting started, real effort at the time, which have really increased. But what we did see here, and here the lead author, Ann Goddard, after 2 rounds of data collection, cross-sectional, and being able to compare that, and also some qualitative work. Next slide, please. We see that HIV service uptake improved over time in Eswatini, for example. So testing went up across the board. I mentioned those different risk groups. So there were younger and older, very at-risk grouping of men. We did this kind of HIV risk profiling through latent class analysis to identify how different groupings of men kind of fell out separately. There was also an older group who were very much not engaged in risk at all, or represented low risk. You kind of see that group as we go across from the red to the orange to the green. So that we saw. We also saw risk behaviors in South Africa decrease substantially, including or especially amongst the highest risk profiles. So that was a positive development. But at that time, there was quite low exposure, somewhat low exposure to prevention programming. So it wasn't due to prevention programming, at least in the way that they reported it. Okay, thanks so much. And I think that might be my last slide. I don't think I have a concluding slide. Next slide. Oh, no, I'm sorry. The last slide is about the qualitative work, which is the promise of gender transformative programming. So for those who were exposed to activities, we saw that the male partners of young women really described benefits from learning about gender and social norms from their partners and what they went through, as well as their own participation when they were included in programs. So for example, and if you look at the quote on the right, on the bottom, my partner and I now know how to communicate with each other. We no longer have arguments over simple things. And so that's a kind of outcome that men were reporting after experiencing or hearing from their partners. Programming focused on gender transformation, improved communication, reducing conflict, reducing side partners, and more impetus to link to HIV services. Next slide, which I think is the last one. And so thanks so much. And I will stop there and turn it over to our third presenter, Dr. Wang. Thank you.
Hello, everyone. Thank you very much for coming to the presentation. So I'm Associate Professor at the Department of Prevention and Community Health. My research is focused on the psychosocial behavior and the application of advanced statistical methods to the psychosocial research. Next, please. So today I will present the e-poster I presented at IAS conference. This is substance use, depression, and ART non-adherence among female sex workers living with HIV. Next, please. So globally, female sex workers are disproportionately affected by HIV. They experience about 30 times greater likelihood of acquiring HIV infections than the general female population. In addition, the female sex workers living with HIV have worse HIV outcomes compared to the other adult women living with HIV. Part of the reason is a lower antiretroviral therapy adherence among female sex workers. Substance use and depression has been reported as important barriers to ART adherence among people living with HIV. Unfortunately, the prevalence of substance use and depression is very high among female sex workers. However, few studies have assessed the relation among female sex workers on substance use, depression, and ART adherence, especially in the longitudinal studies. Next, please. So to fill the gap, we used a sample of female sex workers living with HIV in the Dominican Republic who participated in a longitudinal study, and we assessed two research questions. One is whether prior substance use predicted subsequent ART non-adherence, and the second is whether depressive symptoms mediate the relation. Next, please. So the sample includes 240 cisgender female sex workers living with HIV in the capital of the and they participate in 3 assessments annually, including face-to-face survey interviews and blood draws to test the viral load. Next, please. So ART non-adherence was assessed based on IAS clinical trial group measure with 5 behavioral items, such as whether you have missed a dose of the last 4 days. A sub-score was created with a high score indicating more non-adherence. Substance use include 2 measures. One is illicit drug use and one is at-risk drinking. Illicit drug use indicates whether the participant used any illegal drug in the last 6 months. And at-risk drinking was assessed based on alcohol use disorder identification test, and the cutoff is 3. The mediator depressive symptoms was assessed based on the patient health questionnaire. So with a high score indicating high depressive symptoms, mild to severe depression and moderate to severe depression was defined based on the cutoff of 5 and 10 separately. We also control for covariates in the analysis. Next, please. So cross-vector panel model, which is a longitudinal structure equational modeling, assessed the bidirectional relation between substance use and the ART non-adherence. So for example, we assess whether previous substance use predicted later ART non-adherence and whether ART non-adherence predicted later substance use. So for the second research question, we use autoregressive mediation model, which is a longitudinal mediation analysis. So it's based on the product of past coefficients. Next, please. So this table shows selected sample characteristics. So we can say that on average, these female sex workers are about 40 years old. Most of them are single. So 9 to 15% used illicit drug use in the past 6 months. 53 to 70% reported at-risk drinking. For the most of them have used ART non-adherence. And viral lung suppression varied from 16% to 27%. So 46 to 70% had mild to severe depression, and 14 to 38% had moderate to severe depression. Next, please. So this figure shows the results based on the cross-necked panel analysis. So it's a little complicated, so I will spend some time in explanation. So drug 1, drug 2, and drug 3 indicate illicit drug use assessed at each of the 3 time points. And the ART non-adherence 1, 2, 3 indicates ART non-adherence assessed at time 1, time 2, and time 3. So the straight line with one arrow, a single arrow, indicates the path coefficient, which is similar as the linear regression or logistic regression coefficient. And the curve with double arrows indicate the correlation. So if the line or the curve are solid, it means significant relation. If they are dotted, it means non-significant relation. So if you look at the middle of the figure, this indicates a cross-necked relation, which means, so if you look at the orange line linking illicit drug use at time 1 to ART non-adherence at time 2, there is a significant relation. Similarly, illicit drug use at time 2 predict ART non-adherence at time 3. If you look at the reverse direction, which is ART non-adherence at time 1, with illicit drug use at time 2, there is no significant relation because it's a dotted line. So basically, in summary, this figure shows that illicit drug use predict later ART non-adherence. However, ART non-adherence did not predict later illicit drug use. Next, please. So this figure shows the really bidirectional relation between at-risk drinking and the ART non-adherence. So if you look at the middle of the figure, there is no significant bidirectional relation between at-risk drinking and ART non-adherence in either direction. So no relation. Either at-risk drinking did not predict ART non-adherence, and ART non-adherence did not predict at-risk drinking. So one beauty for the cross-necked panel analysis is that it controls for the autoregressive relation as well. So if you look at the lines linking alcohol use 1 to alcohol use 2 and alcohol use 2 to alcohol use 3, so this is the autoregressive relation. And also you see that the autoregressive relation linking ART non-adherence 1 to ART non-adherence 2 and ART non-adherence 2 to ART non-adherence 3. So it controls the influence of the same variable from previous assessment to a later assessment. Next slide, please. So this is autoregressive mediation analysis. It's more complex than the cross-necked panel analysis. So first, we include an additional variable, which is DEP, which means depressive symptoms in the model. DEP1, DEP2, and DEP3 indicates depressive symptoms assessed at time 1, time 2, and time 3 separately. In addition, different from cross-necked panel analysis, now we don't have the bidirectional relation because we have already found illicit drug use predict later ART non-adherence. So we only have one direction. So you can see illicit drug use predict depressive symptoms, and the depressive symptoms predict ART non-adherence. So we are mainly focused on the temporal ordered mediation, which means we focus on the line which linking illicit drug use at time 1 to depressive symptoms at time 2, and also the depressive symptoms at time 2 to ART non-adherence at time 3. So both of them are dotted line indicates that they are not significant differently from zero. A form of mediation analysis based on the product of the two-pass coefficient suggested that there is no significant mediation effect of depressive symptoms on the relation between illicit drug use and the ART non-adherence over time. Next, please. So similarly, when we assess depressive symptoms in mediating the relation between alcohol at-risk drinking and ART non-adherence, both of the lines are dotted, means there is no significant relation, and a form of mediation analysis suggested that depressive symptoms did not mediate the relation between at-risk drinking and ART non-adherence over time. Although we did not find a mediating effect of depressive symptoms in the relation, however, if you see the purple line linking depressive symptoms at time 1 to ART non-adherence at time 2, it's significant. This is solid line indicates there is a significant positive relation between depressive symptoms at time 1 and ART non-adherence at time 2. Next, please. So in conclusion, illicit drug use predicts subsequent ART non-adherence in female sex worker living with HIV. However, the relation was not explained or mediated by depressive symptoms. So these results suggest that it's critical to prevent and treat both substance use and depression among female sex workers living with HIV in order to improve their HIV outcomes. Next, please. This is a very unique study to disentangle the longitudinal relations among substance use, depression, and the ART non-adherence among female sex workers living with HIV. However, it also has limitations. So ART non-adherence was self-reported and may be subject to recall bias. However, we have conducted analysis and found that ART non-adherence predict virus suppression. Also, the temporal relation between illicit drug use and later ART non-adherence does not necessarily indicate a causal relation because it's an observational study. The modest sample size might also reduce the power in our analysis. So, for example, we found the at-risk drinking is actually marginally related to ART non-adherence. The p-value is 0.1. So, in the future studies, we might future study might use a larger sample size to assess the relationship. Next, please. Yeah, so we acknowledge the District of Columbia CEPA for the pilot award to me, and also the NIMH, our one study to support this project. We also thank all the participants in the study. Thank you so much.
Thank you everyone for such a great presentation. I'm actually learning a lot reviewing them and listening in. Before we get started deep to the discussion, I know there's a comment in the chat that I wanted to see Dr. R wanted to take a moment to talk about. Do you want me to read it or you want to just go ahead and talk about it?
No, I can talk about this. Thank you, Khadija. And actually was going to wait to have Laura speak. She's from ECPAF. She's done a lot of work on pediatric and her comment is directly related to her work. But I just, she left. But anyhow, let me answer this comment and I will follow up with her email. I already know that she had to drop off for another call. She made one comment that covers two elements of data. First one, she commented on the PENTA trial study, longitudinal follow-up of the children who started treatment very early on. And what she said is poor 24 months follow-up for children living with HIV really impacts interpretation of results. For example, the mortality is only 84 out of 212 kids were available. That is correct. They only have 84 children that are followed in the cohorts through the duration of 2 years. They have still children there who didn't make it all the way to 2 years. And it is correct what Laura is saying is that we do have loss to follow up in children. They had a good retention in this cohort, but nevertheless, there was another presentation which I didn't include because of the time that looked at loss to follow up. And it is true that we are really underestimating pediatric mortality in young children, but also in older children. There was a really good study at the pediatric workshop at IAS that looked at loss to follow-up. And it is indeed the case. We think our estimates of mortality are very suboptimal. So I could not agree more with Laura on that. And we just have to see for the longer follow-up of that study. But I do want to say one more comment on that study, that it's not unique to this study. If you look at Deborah Persad presentation from Hopkins on the cura, and those were made in Croy, they all show you that we losing these children along the line of follow-up, unfortunately, and we believe quite few of them are dead without being registered. That is correct. And the second comment on her is on regards of DTG, and she does point out that it's correct that there's low numbers at the forced viral load, so it is hard to interpret results saying the suppression is maintained. Totally correct, as they had also some positive data, and they commented on it verbally through 60 weeks, but these are single-digit kids because the DTG rollout started in resource-limited settings realistically only in 2021, and COVID impacted some of it rollout. So that is totally correct. And the concern whether this success that we're seeing with switching to DTG will be maintained beyond 2 years remains, and was underlined by the presenters of the data saying we do need a longer term follow-up data. In our clinic where Khadija, you work, we know that even with all drugs available, it was a very strong group of support. We still have kids who already have multi-drug resistance. They are not the majority, and these patients become very challenging to treat. So there is no question in my mind that a lot of research and programmatic community want to see longer follow-up data. And I think at CROI this coming year, we're going to see more prolonged follow-up in next year at IAS conference. Thank you. Back to you.
Thank you for that, Dr. R. Also, everyone who's in the audience, I want to invite you to turn your camera on if you want, so we can have a nice community discussion. But the next question is Dr. Yan. And the doctor is asking, were you surprised that drinking was not related to AART non-adherence?
Yeah, so that's true. I thought, so in our hypothesis, we think that at-risk drinking should be related to the ART non-adherence. However, we did not find a significant relation. So actually, we find it's positive related, but the p-value is 0.1. So I'm thinking maybe it's because that we only have 240, a modest sample size. But if we have a larger sample size, maybe we are able to find a significant relation. So in addition, I think maybe illicit drug use is more extreme case, more severe for the female sex worker. Maybe it's common for at-risk drinking. So it's not, the prevalence is higher. So it's maybe it make it as a normal behavior for the female sex worker living with HIV. So it might reduce the tolerance analysis.
Thank you, Dr. Yan. I actually had a question for you in regards to your study. I know you mentioned that it was a modest sample size. So I was wondering, do you have an idea of how many FSWs there are in the area that are living with HIV, and what percent does your study represent of that population?
Can you repeat it? What percentage of what?
What percent of your study represents a population of FSWs in the area that you studied?
Okay, I think it's 4% in the DR. They have HIV infected. So compared to the general population in DR, so it's much higher. So the general population in DR is about 1%.
Thank you.
You're welcome.
Are there any other questions from any attendees? Yes, Nina.
Hi, everyone. I just had a question for Julie about the optimizing study for girls and adolescents across 3 sites from DREAMS. Were there any effects on PrEP, or did you look at PrEP uptake among for the DREAMS packages and how the package might have affected PrEP? Or maybe I missed that part, or it's published somewhere.
Right.
About that.
Thanks, Nina. So I think that PrEP was just rolling out in most of these contexts at the time. So in the beginning of the program, like 2015, 2016, I think it was only Kenya, actually, maybe South Africa, and then it has rolled out more, but there's been very low uptake of PrEP globally, as I'm sure you know, but certainly amongst adolescent girls and young women for lots of reasons, stigma being one of them. And there wasn't a lot of PrEP rollout or use in the context where we were looking.
Okay.
I guess I'll just leave it there.
That makes sense. Yeah, no, go ahead. Sorry.
But what I do think is useful, this is a broader kind of comment about the analysis, is that you can look at different components of the intervention. So different countries under the DREAMS umbrella considered, there was a package and folks could take every element of the package or some components of it, and so this is a way of, without having sort of a randomized controlled trial, of doing an analysis that looks at different combinations of the package that was implemented there to see what kind of outcomes you would get. And so that's, kind of the usefulness of the analysis. And I think PrEP usually wasn't one of the elements in most of the countries where we were looking. It was more around, I mentioned schooling, I mentioned financial support, I mentioned, what was the other one? Schooling, financial support, and I don't have it in front of me, but those are the types of components that went in there. Thanks.
I think it was parenting or something.
Parenting.
Yeah. Makes sense. Thank you.
The financial support is interesting, Julie, just to say that we are going to have a debate at adolescent workshop in South Africa. And just less than a month, first week of October, there will be debate about the value, whether the financial incentives, any kind of financial support is actually supporting. Those of you who have attended any of these meetings, debate is usually highlighted. It really puts you thinking hat on, pros and cons. So in line of your talk, Julie, I was looking at some data, really amazing. Would be very interesting to see what the outcome will be. I will definitely share, and I will share with the whole group, because I think it's interesting to see young people present pros and cons of that.
Right. And whether it's cash transfers or conditional cash transfers, or how they were defining financial support, because in different countries they had financial support, but it looks quite different. And is it linked to an outcome, kind of the conditional that you are requiring for you to get access to the finances, or is it just here's grants? I mean, in South Africa, many young women are on social grants, and so it will be interesting to hear the outcomes of that meeting.
Sorry, what meeting was that, Nutella? I didn't catch what you said.
Yes, Nina, I can send to you. There is an adolescent HIV workshop. It takes place in Cape Town. It usually takes place on the continent, always in different countries. And this year it's 5th and 6th of October in Cape Town. It's run by Virology Education. It's the same group that runs pediatric HIV workshop and other smaller focus workshop. And this has been already, I think, if I'm correct, 7 years in progress, with some really remarkable attendance by young people, as well as healthcare professionals, programmatic people, PEPFAR, etc.
That's great. Yeah, I would love to learn more.
Yeah, I'll send you the link.
Thank you. Did anyone else have any questions they want to ask the presenters? Yes, Godfrey.
Yes, thank you. And I want to come to Julie and ask about the studies that you did in on intimate partner violence and sexual abuse. Now, IPV is well known to be associated with risk of HIV and so on and so forth, but there's a high prevalence of background prevalence of violence in South Africa and Eswatini anyway. So I'm wondering if you also looked at just not intimate partner violence, but just violence in general, and how that might play a role in your studies.
And that's an excellent point, Godfrey. Hi, how are you? So let's see, where do I want to start? So something I've been thinking about a lot is about intersecting violence, forms of violence, and how IPV is linked to like community violence and et cetera, et cetera. There's a new CDC project that's just got funded that's going to focus more on that in the DC area. So I'm looking forward to being involved with that one and thinking about that in the context of gender transformation. But the point is, I guess specifically what you were saying. So one finding from Kenya, for example, is that the young women experience a lot of intimate partner violence, but also a lot of violence from non-intimate partners. So that's one issue. It's still violence the young women are experiencing, and that really was associated with lots and lots of HIV risk for the young women. That's a different study I'm not talking about now. So that's one point. Another point, what I was highlighting was the men. So then kind of coming to your broader point, there's a lot of violence in societies in general that we're talking about in our society as well. And that it has impacts on not just the young women, but also the men themselves. So what I was highlighting is for these men, they experienced both like witnessing violence against their mothers, but also being exposed to gun violence and also being exposed to being robbed. I mentioned being robbed at gunpoint. There was another question that they felt close to death. It's something like 40% of them said yes, of these men. And all of those factors were associated with negative outcomes for the men. So depression, anxiety, alcohol abuse, but also negative outcomes for the women. A lot of multiple sexual partners and more intimate partner violence. But we didn't look. So that is the lens we brought. Did that cover what you were looking for? Or were you looking for something else?
Yes, no, that did, because just having a background prevalence of violence has all these negative outcomes, as we know, and so just try to explore that a bit more in the causal pathways in terms of leading to bad outcomes, particularly in the HIV area. Yeah.
Thank you.
Thank you.
Thank you. Thank you. Any last questions before we wrap up?
Yeah, I have a question for Julie. It's not very clear, closely related to the presentation, but just to follow up, I'm just confused myself about the relation between stigma and violence. So I wonder, in research, usually we treat violence as a consequence of stigma, or violence as a manifestation of stigma. Yeah, this is just for my own research. Sorry, it's not very.
Yeah, that's an interesting question. So, it depends what you're defining, right? So if you think about how we understand how is stigma manifested, so generally you talk about internalized stigma. I feel bad about myself in some way. I've taken on these stigmatizing views. You also talk about negative attitudes towards people, others, as being stigma, and the consequences of that, which enacted stigma, which would be discrimination. And so in that context of enacted stigma of discrimination, there's a range of behaviors. You could be gossiping about people and not inviting them to your house anymore. But it also goes to kids not being allowed to go to school, and it also goes to violence. So there are well-publicized lots of examples of people experiencing violence as an extreme or harassment, particularly among sex workers, for example. We did an interesting study in the DR, not the one that you're involved with Diana, where we were looking at discrimination experienced by sex workers living with HIV. And there was a lot of extortion, a lot of different types of abuse and violence experienced by sex workers that were measured as, discrimination and stigma. So that That is one issue. But also stigmatize, I think the easiest answer is kind of stigmatizing views of the others can lead to a lot of discrimination, including violent behaviors, harassment, being, physically assaulted, things like that. Does that answer the question that you're thinking of?
Yeah, thank you.
Yeah.
Thank you so much.
This is also not directly related, but now that we have MPOX into the population, particularly around violence and stigma, and the how it's connected, and so just to continue to have this conversation about stigma, 40 years of talking about it, and we're still talking. How dangerous it is for our lives.
Mm-hmm.
So true. I mean, it's still like the opening PowerPoint presentation or slide, or it's the ending slide talking about how in the context of stigma and then all these things, or we weren't successful because of stigma. I mean, it's just it's an ongoing thread for the entire HIV epidemic and targeting particular groups. I talked about the intersectional stigmas, and there's many types of stigmas, and it's a synergistic effects with different identities, etc. And it's happening again with monkeypox. And so we need to, and stigma, I've also done work around stigma related to mental health. I mean, just stigma is throughout society, and we have to think about how to understand it and how to address it more effectively. But what was really promising about that pre-conference meeting at the AIDS conference, because we've been talking about this at the AIDS conference for the last 20, 30 years. So this is, I don't know how many of these things I've been to, but I started in like 1999. And it's been a theme throughout. But one thing that they really highlight is there's a body of work showing how to reduce stigma at this point. And we just need to actively fund it and have it be a goal in and of itself. And so there were a lot of really positive points to that pre-conference day.
Thank you everyone for your comments. Dr. R or Julie, can you, for those who are interested in joining the SIG, Global SIG, can you let them know what they can do to be part of our awesome team?
Tell me again, I couldn't hear you well. Can you repeat?
I said, for those who are interested in joining the Global SIG, can you let them know how they can join our amazing team?
Of course. Vivian, the invitation can be reached out at any point. Anyone who wants to be member, you can just reach to the journal CFAR, and you will be guided to here. So any source is good. Email me if anyone on the team wants to do, Julie, any one of us, Dr. Wang will connect. So just anyone. And if you know of any member in DCCFAR who is a member, just us. But I think, Vivian, your invitation, if you just reply and say, I'm interested to have more conversation. Thanks for giving this opportunity to highlight. I was listening to conversation about stigma, particular comment, George, and thinking it's such a universal issue. Sexual violence, physical violence, it's a universal issue. Alcohol, substance abuse, universal issue. We have kids in our clinic in this city, George, to your point, that have known nothing in their life but violence. That's all they have seen, and that's all they know. And to tell them take your pill every day is very challenging, because they have so much more in their lives and their framework. We buried this last year one young man who has been very non-adherent, a very difficult clinic. He died from gunshot wound. And we felt that we wanted just to be there at his funeral. My providers told me they wanted to take up everybody who came and say, why didn't we do better? Why didn't everyone do better? So I fully agree with you. And I just hope you take this meeting. We talk mostly about global work today. And obviously, Dr. Wang highlighted her work here. We would love to build stronger bridges because agenda is so many ways the same. There are definitely differences. I don't want to say people in South Africa have access to everything we have in this society, but on a human level, there's so many common factors. So if any of these talks just make you think of things, or you know people who think of things, we would welcome continued conversation. We can schedule target discussion with few people. Let us explore what can we do to really build that bridge stronger. I don't know if Julie wants to make any remarks, but that's truly the purpose of our SIG, and I'm grateful, Khadija, that you raised this at the end of the call. Julie, would you like to make some comments?
Maybe just reinforcing briefly the points you make, Nutella. So the purpose of this global SIG is to help build bridges amongst us to develop work together, or actually all the SIGs. And I think that the global nature of it is thinking about the lessons learned that go between sort of our global experience, our international experiences, and the domestic experiences. And there's so many themes, and I think that there are lessons that can be brought in both directions. And so, but in this case, bringing from the global South to the US, I think there's a fair amount there with community-based programming, with implementation science, with addressing stigma discrimination, with addressing gender dynamics more effectively, and gender transformational programming. This is something that's very common internationally and often less so in the US. And so I think that there's a lot that we can do there. And around violence, not just around, we've talked a lot about that. So not just around HIV outcomes, but a lot of associated outcomes and twin epidemics and et cetera. So I'm looking forward to this group being able to do that. So anyone who wants to join us, and we need themes to talk about for our next meetings. We could have focus discussions on different themes. We could have different presenters come in. We could talk about specific proposal opportunities that we might want to pursue together. But one of the main goals of this group is to develop work together. So I look forward to doing that for those who are interested.
I am the chair of the Community Partnership Council for the CFAR. And I just want to say from the community perspective, thank you so much for all the work that you do for us and with us on this. This is such a widely needed. And so I'm so appreciative of everyone on here.
We love you, George.
Pleasure to see you.
Yes, definitely. Well, we're at time. So I want to thank everyone for joining us today. And if you have any further questions, maybe Julie, Dr. R, Dr. Yang, you can drop your emails in the chat and people can contact you if they have further questions about your abstracts or your presentations.
Sure, and we will share out the presentations, I imagine, as well, or the recording you had said, right, Khadija?
Yes.
Yes,
so
Vivian's going to share it.
will be available on the website after.
Thank you so much.
Thank you. Bye,
Thanks
everybody.
again. Take care.
You too.
Thanks, everyone.